My cat is about to jump onto the computer screen, so I'm just trying to stop her from doing it.
You should show your cat to us.
Yeah, you know, it can't be a Zoom meeting without a cat trying to bust into it. So it's the law now. Cats love a Zoom.
Zoom was invented for your pets.
Yeah, yeah. They just think it's great. Now there she goes.
Oh.
Shall we just start?
Yeah, I think that's almost everyone now. Please start, Asta. Thank you.
So I'd just like to inform everyone that the event is being recorded, first of all. And before we start, I'd just like to introduce Dr. Lloyd and Evelyn. So Dr. Lloyd is Senior Lecturer at the University of Manchester, and her research focuses on multisensory and cognitive factors underlying body representation and somatic awareness, including touch, pain, and itch. She's interested in the behavioral and neural traits that predict whether someone misperceived touch using perceptual illusion, signal detection analysis, functional MRI, EEG, and transcriptional electrical stimulation. Evelyn is a third-year medical student at the University of Manchester. She's developed an interest for neuroscience and is working on projects about neurofeedback for chronic pain, depression, and anxiety, as well as prison healthcare. She's a brand ambassador for Young Academics Manchester, and she hopes to expand these opportunities for research to other students as well.
Thank you so much, Asta. Okay, so are we starting with this? Okay, so thank you so much for coming today, everyone. So welcome to our presentation. It's on chronic pain neurotherapy and neuroimaging biomarkers, and it's going to be presented by Dr. Lloyd and me. So what are we going to be aiming to cover today? Firstly, we're going to learn about current research regarding chronic pain and neurotherapy, and secondly, to explore the future directions of pain therapy research. And just an overview about what we're going to be talking about. Firstly, I'm going to be introducing neuroimaging and chronic pain, and then Dr. Lloyd will talk about neuroimaging for clinical pain research. I'll be covering EEG, neurofeedback for chronic pain, and there'll be a Q&A at the end. So leave your questions into the chat. Just put them in anytime and we'll answer them at the end. So pain is our big topic for today. What makes pain? I'd like to give us a bit of background to what chronic pain is. So chronic pain is a huge problem today. There is about 1/3 or 1/2 of the population that has chronic pain. Pain is defined as an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. It's not just nociception. Pain is an individualized experience and can occur even in the absence of nociception. So chronic pain can be due to different conditions, such as back pain, rheumatic conditions, neuropathies, but they can also happen when there's no physical illness, so in somatoform pain disorder. So to talk about pain for this presentation today, we have to have a general idea of how pain works first. Oops, let's go back. So general idea of how pain works. So the mechanism of pain is that firstly, there is some kind of noxious sensation from the periphery. It comes into the spinal cord through a neuron. It synapses with another neuron, goes up to the brain through the brainstem structures, and then to the thalamus. And then through the thalamus, it projects to the pain matrix. So this is the pain matrix in the cortex. It includes the anterior cingulate cortex, the somatosensory cortex, the insula, and the prefrontal cortex. From there, they also send descending modulatory projections towards the spinal cord, and this serves as endogenous analgesia. There's also another theory called gate control theory, and it tells us that some neurons and interneurons in the spinal cord help to modulate incoming signals from the site of pain, which will influence the way the signal goes up to the brain. So just thinking about this, pain is the master center of pain. The brain is the master center of pain. It's so important, and it's tells us how we perceive pain. And because the brain is so important, that's why we have to do neuroimaging. So today, Dr. Donald Lloyd would be talking about different neuroimaging techniques, but just a general overview. The main imaging modalities are PET, fMRI, and EEG. PET is positron emission tomography. PET is typically used to scan the chemical events taking place in living tissues at receptor and neurotransmitter reuptake sites. PET can also be used to measure regional cerebral blood flow, blood volume, and oxygen uptake, and glucose metabolism. fMRI is functional magnetic resonance imaging. It's used for indirect measurement of brain activity via the blood oxygen level dependent response, and this is called the BOLD response, which is a measure of the amount of deoxygenated blood and blood volume in brain regions involved in the response to a stimulus. And EEG, electroencephalography, an EEG signal is measured at the scalp and represents discharge from postsynaptic potentials of cell bodies and dendrites of cells in the cortex. This technique is very time sensitive, but it doesn't provide a lot of spatial resolution. So a lot of times when we do neuroimaging, we combine EEG with fMRI. And with neuroimaging, you can visualize activation of brain regions in the presence of pain and can also compare this to individuals without chronic pain. And so next, I'd like to pass on to Dr. Donna Lloyd to talk about neuroimaging and her own research.
Okay, right, let me just try and share my screen. There we go. Okay, can everyone see that okay? Just...
Yeah, looks good.
Is that all right, Evelyn? Brilliant. Okay, so basically what we've got here is a slide very similar to what Evelyn just showed you. And it's really to emphasize the fact that we are interested in the brain when we are, that the brain really, as Evelyn said, is the major centre of pain perception. And clinical pain neuroimaging obviously focuses on the patient's response to their own pain, their clinical pain, or to an experimental pain stimulus that we give them. So clinical pain neuroimaging is the study of how the different neural systems of the brain contribute to this pain experience, and that can be the perception of pain, or it can be how people express pain, and it can be whether pain is acute or chronic. And the images here just show you somebody lying in an MRI scanner and receiving a painful stimulus. So on their index finger here, there might be a thermal stimulus that heats up to a painful temperature. That's a typical kind of experimental pain stimulus we might give somebody. You can see the electrode maps in the bottom corner there of somebody having their EEG recorded, or you can see the functional MRI scans that we get. Those red areas just indicate increased blood flow, basically, and that's the marker that we're looking at with functional MRI. It's actually the difference between oxygenated and deoxygenated blood in the brain, and we use that as the marker of neural activity. Indirect marker, of course, but that's what we use. So when we talk about clinical pain neuroimaging, we're really looking at we're really focusing on those biomarkers that tell us, that link somebody's pain perception, what they tell us subjectively, with a change in the neural response or change in brain function. And the two biomarkers that seem to be quite important and that there's a lot of focus on at the moment are central sensitisation. So this is an increased brain response to a normally painful stimulus. This is like I was saying before, when you would give somebody an experimental pain stimulus, like a heat pain stimulus, and that would evoke a particular activation a reaction in those pain pathways that Evelyn's just told you about. But in somebody with a chronic condition like chronic low back pain or fibromyalgia, which, if you're not familiar with fibromyalgia, is widespread pain across multiple sites in the body. It feels like having the flu, but people have this all the time, every day. It's a highly distressing chronic pain condition. They would show an increased response to this normally painful stimulus. So these brain areas would be activated even more. They're sensitised. And these activations can be further increased by various psychological factors. And you'll find the ones that are typically focused on are things like anxiety and depression, which is comorbid with a lot of chronic pain conditions, but also something like catastrophizing, which is where somebody has a very negative belief about future events or about a particular situation. So if we're talking about catastrophizing for illness perceptions or pain perceptions, this is where somebody believes that the pain will never get better. There is no cure, there is no help for them. And again, it's very common in people with chronic low back pain, for instance. Another marker might be something like changes in the connectivity of these brain regions, or changes in certain neurotransmitters that we can measure with PET. Or we might see evidence of cortical reorganisation. So this is actually where the brain has changed its functional maps, if you like, in response to a chronic pain condition. And that's the one that I'm going to focus on first of all. And we're going to take as our example here phantom limb pain. So in phantom limb pain, what we have is it's a common clinical pain condition in people with amputations, obviously, so it affects up to 80% of all amputees, and treatments are largely ineffective because we don't actually know the cause of the pain. And so most of the therapies that seem to be most effective are psychological therapies around providing sensory feedback to that deafferented limb. So it's really about restoring, if you like, the functional representation in the brain of that deafferented limb. And animal research has shown that after an amputation, the brain does reorganize its bodily maps, and you get invasion of adjacent cortical areas into that section where that did belong to that deafferented limb. So that suggests that there's the change in the way the body is represented in the brain following amputation. So I'm sure you're all familiar with Penfield's somatosensory homunculus. But here we have a map of the body that's in the postcentral gyrus, so it's kind of coming around this way like that. So starting with the bottom of the body, the legs and the feet at the top there, and coming around with the hands and the face down towards your ear here. So that's represented in the postcentral gyrus. And what we know is that the amount of reorganisation that occurs after somebody has an amputation is highly correlated with the amount of pain that they experience, phantom limb pain that they experience. So there is a connection between the changes in the brain map and the amount of pain that's felt. What we find is that the mouth area, the face area, invades the adjacent hand area of the somatosensory cortex. Of the deafferented limb. It's no longer receiving input from the periphery. And so they are clearly separated in patients who don't have phantom limb pain, but they overlap in people who do. And so, of course, the question is, if we can undo this overlap, can we treat phantom limb pain? So a very well-documented way of targeting somebody's phantom limb pain and restoring that functional representation of the deafferented limb is to present them with a mirror image of their limb. So if I can just show you this picture here. So if you can see in the bottom corner of the screen, we have a gentleman with a lower limb amputation. But if he looks in the mirror, he sees his intact leg in place, and it seems to be a mirror image of it is where his amputated limb is. So he appears to now have two lower limbs. So that can give that functional impression of that feedback, that visual feedback, if you like, that a limb is now in place. And here we've got a diagram that just basically shows the kinds of sensations that people with phantom pains report. Really horrendous, burning sensations. The limb will feel like it's in an unnatural position. There will be cramps and stabbing sensations. So anything that we can do to kind of reduce these sensations through treatments like providing visual imagery is hugely helpful to these patients. So we wanted to look at whether, if we give somebody a clinical intervention, a course of visual feedback, can we actually reorganize the cortex? So instead of those areas of the brain being overlapping in somebody with a phantom limb, with phantom limb pain between the mouth and the hand area, will they now go back to their separate somatotopic locations? So this is what we wanted to do in this study. We're using fMRI to demonstrate those changes in the brain. And instead of using a mirror box, we want to see whether we could use something that was a bit easier for patients to actually use. So as a means of gaining control over their phantom limb. So we tried mental imagery, and we used meditation training as a way of people gaining that, if you like, cognitive control over their body. I'll explain how that works in a second. So we had upper limb amputees, and we gave them a clinical interview to ask them about their current pain. We measured their pain and various other things as well, like their medical, their use of medicines and coping strategies and things. And in the fMRI scanner, we got them to do a lip purse, which is basically blowing a kiss, because obviously we want to map the brain area that responds to activation of the face and see how much that's invaded the hand area. So we got them to do that in a set of scans. Another set of scans, we got them to imagine opening and closing their phantom hand. Most people with phantom limbs have a strong impression that they can move their phantom. And the idea was, after the mindfulness training, they should be even better at being able to do this, because they will have trained themselves in visualizing opening what can be very cramped, sore phantom sensations. We also got them to imagine opening and closing their intact hand as well. And of course, we repeated these scans before and after they had their intervention. So what we found was that there was huge amounts of pain relief following the intervention. The dots on your graphs are the before intervention, before training, mindfulness training, and the stripy bars are the ones that are after training. And for both pain intensity, which is just kind of the baseline pain intensity, and also what we call exacerbations of pain, which these kind of breakthrough pains, really painful, sharp episodes of pain, both of those had reduced after this clinical intervention. I think I've skipped, because it hasn't. Let me just go. Oh, there we go. There's the clinical intervention. I thought I'd skipped a slide. Sorry about that. The clinical intervention was basically 6 sessions of a body scan exercise, which, if you know anything about meditation and mindfulness and body awareness, you basically are encouraged to think about the sensations in your body, and the position of your fingers, your temperature of your body, all these kinds of things. And we got them to imagine stretching away the pain, moving their painful phantom, and they were given a CD to work on this technique at home. So now I can tell you about the intervention. Right, so 50% had pain relief. 6 participants were now completely free of their exacerbations of pain, which is amazing. And also, of the 3 patients taking analgesia, 2 had stopped completely, and 1 had reduced their requirements, and they'd also stopped taking their sleeping tablets as well. So from a clinical point of view, this was a huge benefit to these patients. The fMRI results, I'll try and show you on the screen. Let me see if I can get my a marker pen here. Right, here we go. Laser pointer. Oh, good. So this is the before the intervention scan. Here we've got a coronal section through the brain. So this is if we slice the brain in this orientation, and we're at the level of the somatosensory cortices here. This is the face area. Okay, so of course they're doing a face, task, they're pursing their lips. So huge amounts of activation in the face, as we would expect. What we wouldn't expect is to see activation in the hand area. So this is showing you how there's been this overlap in these patients before they have their clinical intervention. Afterwards, we only see the activation in the face area, not in the hand area. So we've reorganized their brains back to, if you like, a pre-amputation state. And we've changed their clinical outcomes as well, and their reduction in pain. We'll also find that there is a sorry, just turn the laser pointer off. There we go. After training, you also don't see excessive activations in the face area when they're imagining moving their phantom hand, because this sort of overlap goes in both directions. And as you might expect, imagining moving their intact hand, we don't see any difference in that before and after intervention. So that's just a nice control condition. So this technique of mental imagery did result in pain relief, and it was consistent with this change in cortex and reorganisation. Even those who didn't find a change in their pain, they still found the technique very relaxing. And this is consistent, this kind of use of visual imagery as a benefit for lots of chronic pain conditions like complex regional pain syndrome, if you're familiar with that. So when we look at chronic low back pain, there is also evidence to show that that is also associated with cortical reorganisation, that there are changes in the somatotopic representation of the lower back in these patients. There's also a change in central sensitisation, so the brain regions that respond normally to pain are responding even more so, and this is particularly the case when we look at psychological factors like fear avoidance or anxiety to threat-related stimuli. And the suggestion that there is a mechanism here whereby these psychological factors are exacerbating and maintaining this central sensitization, this increased brain response. So it's important to look at these psychological factors alongside the brain response as well. So the next couple of studies I'm going to tell you about is where we've actually looked at changes in the psychological and the pain behaviour of someone alongside their central sensitization in response to a painful stimulus. So first of all, in this study here, these activations that you see, this is an axial slice, so it's going through that level of the brain. We see some activation when we stimulate the lower back. This is a non-painful stimulus, actually. This is innocuous. But in people with chronic low back pain, there's a slight shift in where that representation occurs. So it's, if you can see the Z values here shift up from 64 millimeters to 66 millimeters. So it's not as clear cut at all as the phantom limb pain, but there's a slight shift in cortical reorganisation. What's much more apparent is that there is a lot of central sensitization in patients with chronic low back pain, and there seems to be activation of the affective, the emotional circuitry of the pain of the brain. So in this study, we scanned patients with chronic low back pain whilst they received a thermal pain stimulus onto their finger, as I explained before. But we split the patients into two groups. Some had a lot of comorbid psychological factors like depression and anxiety, and a lot of pain behaviour associated with their chronic low back pain. So they were highly pain fearful and anxious. And some chronic low back patients didn't have that psychological profile. And what we find is, in those patients that have the major pain behaviour, they show an increased activation in the area of the brain, which is very linked with the areas of the brain which is very linked with the emotional circuitry of the brain, the amygdala and the ventrolateral prefrontal cortex and the insula. So this is what I'm showing you in this slide here. We've got a coronal section. Again, that's that slice that comes down like that. And now we're at the level of the amygdala. So we're really right in the centre of the brain there in the temporal lobes. It's a very small area to scan. But if you look at the change in the blood flow signal, the bold signal, The WSL are those people with very little pain behaviour. They don't show much difference in the amygdala between whether they get a hot, painful stimulus or a warm stimulus. It doesn't matter. In the patients with a lot of pain behaviour, they get a much higher response in that to the painful stimulus in the amygdala. And so there's a suggestion that it's this central pain response that's linked with and mediated and maintained the psychological distress in this group. That obviously, giving somebody a thermal pain stimulus is a very experimental stimulus. It's good because it's easy to control, but it's not very meaningful to somebody's chronic low back pain. That is not the kind of pain they're experiencing. So in this final study I'm going to tell you about, we used a more clinically relevant pain stimulus to activate these pain regions. And the stimulus, the pain task that we used was a straight leg raise. This is used clinically a lot to assess how much pain behaviour and pain anxiety somebody has. If you perform the straight leg raise under distraction, people with low back pain, they don't say it causes them any pain. If you don't perform it under distraction, so you're literally sat in a chair and you're just raising the leg, they say please don't do that. That's causing a lot of pain to my lower back. So they are very wary and very mindful of those kinds of procedures. It's one of a series of procedures called the Waddell signs that are used to assess how pain anxious somebody is. So if we perform this straight leg raise in the scanner while recording and trying to measure their fMRI without getting them to move too much, because that ruins your MRI signal, then we find activation in a number of regions, but again, they are generally related to regions involved in threat and pain anticipation. So again, there's a suggestion that these are exacerbating the pain behaviour that people, some groups with chronic low back pain have. So we see activation in the superior parietal lobe at the back there, in the insular again, which we've already spoken about, and the anterior cingulate cortex, which is mentioned a lot in the emotional response to pain. It's linked in with the unpleasantness of pain. So I'm just going to finish by introducing what Evelyn's going to talk about next, because this is all well and good identifying these biomarkers with imaging. But of course, what we then need to do, if this is going to be translated into a therapeutic course or outcome, we need to target these brain regions. And there are a number of ways of doing it. And recently, people have been using transcranial electrical stimulation directly stimulating the cortex through the skull, applying electrode pads. So I had a look to see what the evidence was for the efficacy of this technique in fibromyalgia pain and reducing fibromyalgia pain. So we did a systematic review and a meta-analysis, and it did suggest that if you apply direct electrical current at an intensity of about 2 milliamps to motor cortex for 20 minutes a day, for 10 sessions, so over 2 weeks, you get a lowering of subjective pain intensity scores in fibromyalgia patients. It's a small change, a percentage change, it's small to moderate, but there is a reduction. So there's a future avenue there to translate these clinical pain neuroimaging biomarkers into some therapeutic neurotherapy techniques. And now I'll pass over to Evelyn to continue with that discussion.
Thank you, that was really good. Okay, thank you. Let me share the screen. Okay, so this part of the presentation will be talking about changing these neuromarkers that Dr. Donna Lloyd talked about into neurotherapy. So EEG neurofeedback for chronic pain. And this is thanks to the Human Pain Research Group, in particular, Professor Anthony Jones and Dr. Donna Lloyd for supervising my projects. So what is EEG neurofeedback therapy? It is a type of biofeedback that uses a brain-computer interface for self-regulation of your own brain signals. It's presented in audio or visual format, and it's measured with EEG and presented in real time. So neurofeedback has been the focus of research for many neuropsychiatric conditions, including chronic pain, schizophrenia, ADHD, anxiety, depression. It's even used for improving your performance in a lot of people like musicians, surgeons. So neurofeedback has a wide range of uses. And just a little bit about how it works. So firstly, EEG signals are made by synchronous activity of neurons that produce oscillations, which are picked up by the electrodes on the scalp here. Then the signals are then sent to the computer, and then the computer processes all these signals and presents it on a screen, either in audio or visual format, so that the user can see it in real time. And so once they see it in real time, they can change the way their brain signals work. So how do they change these signals? What are the signals like? So this is a diagram. I'm not sure if you can see very clearly. This is a table outlining how aligning the different frequencies of EEG. So it's grouped in different bands, delta, theta, alpha, SMR, beta, high beta, and gamma. So they all actually correlate to different characteristics. So for example, alpha is correlated with alertness and peacefulness, readiness, meditation, deeply relaxed. And high beta is correlated with intensity, hyper alertness, anxiety. So you can see how if someone wants to improve chronic pain or anxiety, they might want to increase alpha and decrease high beta, for example. So just by using these EEG signals, you can do neurofeedback and try to improve your symptoms. So what are the benefits of this therapy? You can regulate brain activity and grasp strategies to achieve different targets. You can practice and identify strategies to regulate your EEG signals so that you can use the same methods outside of neurofeedback to improve your symptoms and improve your performance. It's a non-invasive and it has minimal adverse effects. And it also places the patient at the center of treatment, so improving self-efficacy and also causing beneficial psychosocial effects. And so how is EEG used in chronic pain? So we now know that different band waves or brainwave frequencies are correlates with different characteristics. So things like these, but actually we've already found that chronic pain is associated with abnormalities in these frequency bands. So for example, chronic pain is associated with decreased alpha power. Alpha activity is significantly lower in patients with chronic pain compared to patients without pain and healthy controls, one of the studies found. And also frontal alpha is involved in top-down control in the brain. So top-down control like here. And placebo analgesia also increases frontal alpha. Alpha power is suppressed when there is an expectation for pain. So expectation is also important for pain. And secondly, chronic pain is associated with increased beta power as well. Beta is associated with attention and alertness and may be raised when there is increased attention to afferent pain signals. It's also associated with theta power, increased theta power. So theta power is known to be increased in chronic pain, especially central neuropathic pain. This is through thalamo-cortical dysrhythmia due to disinhibition of the thalamic nuclei, and it results in an increased theta power in prefrontal medial areas and the anterior cingulate cortex. Chronic pain is also associated with decreased SMR power. So SMR is sufficient in chronic pain, anxiety, panic disorder, and other mood disorders, and is thought to be produced through thalamo-cortical interactions during suppression of gating of afferent somatosensory signals. And so knowing these abnormalities associated with chronic pain, you can use these different frequencies as neurofeedback targets and also monitor the efficacy of a therapy you're working on. And so what are these, how do these neurofeedback training protocols look like? So a lot of times studies like to compare or combine different targets for the frequencies together. So sometimes a lot of studies do alpha and beta together and also alpha and theta together. And they try to target increase or decrease of those frequency powers in different areas of the cortex. So you can do neurofeedback in the central areas, temporal areas, frontal areas, or parietal areas. Neurofeedback sessions are often 30 to 45 minutes long. You can have 20 to 40 sessions, 1 to 5 times a week. And it's provided in different ways. So we've already talked about how it's auditory or visual feedback, but you can change the volume of sound, you can change the height of different bars, you can change colors, you can play a game with it, you can combine auditory and visual feedback. So it's very, it can be tailored towards the patient. So it's also it can be used for children, for example. And so this is the literature review that I worked on, and it's called Comparing EEG Neurofeedback Approaches for Chronic Pain, Depression, and Anxiety. So why chronic pain, depression, and anxiety? Why all three symptoms? So Dr. Lloyd has told us about how important it is that there are chronic pain behaviors and also psychological behaviors that can kind of make your chronic pain worse. So we can see there's actually a high prevalence of comorbidity, shared networks, and shared treatments between those three symptoms. Up to an average of 50% of chronic pain patients actually have symptoms of anxiety and depression. But a lot of studies for neurofeedback focus on these conditions separately. So in this literature review, I wanted to kind of combine all these symptoms together so that we can see whether neurofeedback can be a cost-effective way to treat pain and its comorbidities together. So the aim was to review and compare different protocols used by neurofeedback studies for chronic pain, depression, and anxiety in order to aid the goal of identifying a method to target all three conditions at once. So I compared different training protocols and targets, and also looked at the changes in the pain and chronic pain related symptoms, including depression and anxiety for these studies. And what I found is that the most common protocol for the three different symptoms was regulating alpha. So alpha modulation is the most common protocol. And we see in two of the studies that they try to upregulate alpha for patients with chronic pain, and anxiety and depression also improved for these patients. So there is a future possibly for alpha modulation to improve multiple comorbid symptoms together. And so this leads us on to the next step, which is a systematic review that we're going to be working on. And it's going to be about efficacy of alpha modulation for comorbid symptoms of chronic pain, including depression and anxiety. So what is this alpha rhythm we're talking about? What is alpha modulation actually? So alpha rhythm is an 8 to 13 hertz oscillations associated with relaxed wakefulness. It's involved in sensory processing via top-down control or attentional suppression, and may play an active role in the processing of pain. Alpha, we already know that alpha activity reduces an acute experimental pain. Enhancing it before the onset of pain reduces pain intensity, and alpha activity is influenced by attention and expectations about pain. And we know that in chronic pain patients, there's already a low baseline alpha activity. And so because we know all this, it's really important that we now study how alpha modulation can improve comorbid symptoms of chronic pain. And so this is the future of chronic pain therapy. The problem right now is that a lot of people have chronic pain. There's a huge cost and urgent need. A recent survey revealed that 40% of chronic pain patients felt that their treatment was inadequate and with a substantial preference for non-drug therapies. And the only therapies that have seen long-term benefits without significant harm are cognitive or talking therapies and exercise. But sometimes these are limited by cost, mobility, and acceptability issues. So that's why there's a need for non-invasive, non-pharmacological, cost-effective, and easy-to-use ways to alleviate pain. So the Human Pain Research Group has developed this Manchester Smart Neurotherapies platform, and it uses alpha modulation neurofeedback. And it's used on an app that you can do at home. And there's two ways you can use it. Firstly is alpha entrainment. So it's using these goggles with flashing lights that create rhythmic stimulation at alpha frequency, or using earplugs that create a similar effects with sound. And this tries to increase alpha waves in your brain. And secondly, neurofeedback, which we've already talked about. It increases the brain's resilience to pain in the longer term. It's wireless to the mobile app and also to your computer. So the thing about this is that it's so easy to use, and also you can make your own decisions about your treatment and your own home with minimal technical assistance. So that's the future of chronic pain therapy. So today we've covered the main aims. We've talked about current research and also future research. We know that chronic pain is a big problem. There's a need for new non-pharmacological treatments. Clinical pain neuroimaging may one day provide predictive neurological signatures of chronic pain for targeted treatment, prognostic measures for risk assessment for elective surgery, and personalized treatment for chronic pain subgroups. This is what Dr. Lloyd has been talking about. And also from our presentation, we found out that neurofeedback can provide pain relief and also potentially relieve mood symptoms in chronic pain patients. There's a future for neuromodulatory therapies that put patients at the center of treatment and can target a wide range of symptoms. So that's it for what we're talking about today. These are our references. And if you have any questions, you can put them into the chat. Thank you.
Right, so we have two questions in the chat. So Mazak found examples of individuals born without a limb who had events or phantoms in a paper way back in 1998. Do you know if any work has gone into studying patients like this more recently? It would be interesting to compare these cortical organizations to the general population.
Okay, I think that's one for me, isn't it? Yeah, it's an interesting one, the congenital absence of limb. Certainly do report pain, but I don't know that there's been any studies that have actually scanned them and looked at the amount of organisation, so or reorganisation rather, and I'd have to check that one, Joseph. So I mean, definitely have phantoms, and they do report pain, although I think it's to a lesser extent than people who've had an amputation sort of later on in life. So I don't know that any work's been done on this population recently. That would be, yeah, that's something to follow up on that one. Do you want me to take the next question? Hypermobility causing pain? Hypermobility certainly can cause pain, definitely, because if you have hypermobile joints, you are very prone to overstretching those joints without even realizing it. Even the most innocuous movements, you can quite easily overextend, tear ligaments, tear muscles, and cause yourself quite a lot of pain and tissue damage, but then sort of you get a lot of tissue debris that builds up after that as well. So it can be a real problem. People who are hypermobile need to be very, very careful with their movements. Oh, thanks very much for that. I've not heard of Mike Linnett. That's a great suggestion there, Joseph. Thank you very much.
Thank you. Okay, Kamal has asked, can social factors influence pain perception therapy?
Say that again, sorry. Sorry, I was reading the next comment
Yeah.
there. Say again.
Can social factors influence pain perception in therapy?
Oh goodness, yeah, hugely. Social factors, you know, is a very broad umbrella term there. But if we're talking about pain therapy, then the social factors that are hugely important are your perceived perception, you know, your perceptions of your family and friends and how they respond to your pain. So there's been quite a lot of work on how patients with pain perceive their spouse's response to their pain. And again, there's a link here with catastrophizing. So if you are a patient with a chronic pain condition and you are a very high catastrophizer, and I'll just say, by the way, we're all catastrophizers, you know, on a spectrum. You know, this isn't like a special thing that only applies to chronic pain patients. It doesn't. Much like we all get anxious, you know, it's on a spectrum. Some of us get more than others. So you will know yourself if you're a catastrophizer and you make, you know, you have a very negative outlook on things. Anyway, if a patient with chronic pain is highly, you know, does rate a lot of pain catastrophizing, they are more likely to say that their spouse is not helpful, is punishing them, you know, is just not giving them the support that they feel that they need. Of course, interestingly, when you then ask the spouse, they say that they are giving a lot of the support. So there is definitely a very complex interaction there between the psychological factors that the patient is currently experiencing, how that makes them perceive other people's response to their pain. Yes, there's been quite a lot of work on that. There's a guy called Michael Sullivan does a lot of work on this, and his theory is the communal coping theory, that patients with pain will solicit help and cope, you know, that they'll use other people to help them cope with their pain. But if that strategy isn't working, they can then say that it's you know, it's negative. It becomes a much more negative thing. Other factors, other social factors, and things like empathy for pain. How empathic are you? Well, now this is something you guys are going to have to think about, I guess, in your careers. You know, the kind of how empathic you appear to other people when you are providing treatment, support, guidance, information. All those things will very much affect how they then perceive their pain, basically, and how much they interact with you and respond to your suggestions for treatment and, you know, therapy and things. So there's a lot of work on empathy. Interestingly, the areas that are activated when we are shown images of somebody in pain, and where we have an empathic response to that, they are the same brain areas that respond when we experience physical pain. So again, there's that overlap between the visual images of pain, of that visual representation, and the bodily, the somatic representation as well. And that seems to be the mechanism underlying that pain empathy response.
Kind of related to that, this morning I saw a paper that that was talking about like fMRI for like empathy for looking at pain, like you said, but they were comparing whether someone with like an Asian race looking at another person, no, someone with a white race looking at an Asian person in pain would be the same as an Asian person looking at an Asian person in pain. It was pretty interesting.
Oh, but what did they find?
I didn't read the whole thing. I only read the abstract. But yeah,
yeah, no, read the paper and let us know about that. Yeah, I you know, there's always a big, obviously, area of research about how we respond to our in-groups, as they would call it. You know, these are our social in-groups, maybe, and that the response maybe should be stronger for your in-group. But I mean,
yeah, that's what they found, actually.
Yeah, I mean, although we're all humans, so I don't really that's the in-group, isn't it, you know? I would be interested to see what the response was with viewing a human being getting pain and an animal receiving pain, because I would imagine that the brain area, that it'd be the same response. I think our empathy for animals and animals that are hurt and in pain is so strong that I think we show the same activation like we would for seeing a baby who was hurt and crying or anything like that. Anything that was vulnerable and needed us, you know, I think we'd have the same empathic response. I'd like to think we would anyway.
Hazel Spear said, thank you so much for this fantastic event.
Oh. That isn't a baby in pain. That's a baby whinging because it wants its mum. I'm so sorry about that, everyone.
No worries. Okay, we got another question. Can being more empathic towards patients' pain confirm their pain to them and make it feel worse?
That's a really interesting question, and I know what you're kind of getting at there. If you're too empathic, this is an aside, but it's a good demonstration of it. I was taking a walk one day through the countryside with my friend, and I felt something on the back of my neck, you know, like a little tickle. I thought that must be an insect. The next thing I felt was something stabbing me in the back of my neck. So this thing had obviously decided to sting me or take a bite out of me or whatever it was going to do. And my friend helpfully went, oh my God, look at that thing. What is it? What is it? And she's like, oh, are you okay? That must be awful. I really wish she hadn't done that, because at that point I went into a really bad, shock, you know. I was like, what was it? And if she just kind of gone, oh, it was just like a little gnat or something, it was nothing, you know. So her empathic response just made that whole thing so much worse. So yeah, I can completely see how if you've got to tread a fine line there, I think, between showing a level of empathy, obviously, if somebody's very distressed, if they're crying and, you know, really, really distressed, you've got to be a human and, you know, and be empathic towards them. But you've also got a job, haven't you, to do, and you've got to get information across, and you've got to be quite focused and clear in that message as well. So your own empathy can only go so far, I guess. I'm sure there is literature on that, and there is a literature on doctor-patient sort of consultations and empathy, and how much empathy, you know, is used. I think doctors have to be quite careful as well about how much they take in themselves. If you have a patient who's very upset, very distressed, it will affect you. It will make you very upset as well. So you have to be a little bit careful about your own emotional well-being as well.
Sunita said, thank you very much for interesting events. Thank you for coming. Well, I had a question, Dr. Lloyd. You know how you worked on fMRI for illness behavior for pain? I always wanted to look into fMRI and neurofeedback. What do you think is like the main difference, or like the reason why a lot of people do more EEG neurofeedback than fMRI?
Oh, fMRI is hugely expensive. Basically, it's a bottom line cost thing. So I mean, I know there's an author called Charms. He did a nice fMRI feedback study, neurofeedback study, many years ago now. I haven't seen very much since that. He would show people the brain activity, the bold response actually changing. But these scans cost about £400 per patient or per person. And then when you factor in the technology around showing real-time fMRI to somebody, which is not easy. I don't know if you know much about the technology, but there's a lot of signal processing goes into an fMRI image before you get to that pretty brain with the blob on it. It's, you know, it doesn't start out life like that. So to speed that up to such the point that you can show it real time back to somebody and use that as a training signal is a technological feat in itself, really. So I think those are the two prohibitive. EEG now is becoming virtually portable. You know, you can get take home EEG kits. You can, you know, you can buy them off the shelf, you know, a simple 30 electrode cap. It's, you know, it's got to that level now of EEG, so it definitely is much more cost efficient and easier to present those signals, because you can show somebody a raw EEG trace, you know, it won't look great, but actually it will look like, you know, activity, and you can clean it up and make it look prettier, but you can show somebody their raw EEG trace. So yeah, those are the main reasons, really. And I always say work with the best technology for the question that you're answering as well. So I think, I mean, fMRI doesn't work well temporally. It's a great spatial tool, but temporally it's dreadful because the bulb response is so slow. It's like 7 seconds to peak. EEG is great temporally, you know, so it's much quicker. It can show you the time course, you know, practically to the moment. So it just ticks all the boxes, really, in terms of neurofeedback.
Thank you so much. Any other questions from the audience? Also, Komal sent the feedback form in the chat. So if you want to complete that, that would be really, really helpful for me and Dr. Lloyd.
Oh, you're welcome. Good. I'm glad you enjoyed it. Thank you.
Megan asks, can we access the recording? Komal? The recording will be on our YouTube channel. Thank you guys for joining.
Oh. Good, great. Oh.
Hi.